scar, the number of stitches they have, and to me that's not really a big deal, but thought I'd ask. You brought some really interesting pictures, and Phil, if you'll put them up on the screen, we'll get Dr. Andrews to tell us what they are.
The first is an x-ray of someone standing, and you're looking at them from the front. The knee on your right, as you look at it, is the right knee. And what you see, if you compare it to the one on the left, is the black space between the thigh bone, which is above, and the shin bone, which is below, is very smooth and uniform on the one on your left. The one on your right, if you look at the outside, the bone is collapsed down, and that cartilage is completely gone, so that's a bone rubbing on bone problem, and that's a patient who's going to not only have a lot of pain, but as it collapses down, the knee's going to angulate to the side. So they have a difficult time walking, and they will have usually significant pain. This is just a view looking at the kneecaps, the underside of the kneecaps, and you can see how they have this gentle little V-shaped on the bottom. And the knee on your right has much more irregular surface underneath that V-shape than the one on your left. This is a side view that shows the same thing. Again, the patient's hip is above and ankle is below, and you can see on the side the view of the kneecap, and there's a spur on the top of the kneecap, and the surface between the kneecap and the thigh bone is narrowed, and again, that's a sign of arthritis. Now this is just a different patient, and the knee on your left has, I would say, moderate arthritis as you look at the surfaces between the thigh bone and the shin bone. The knee on your right has more significant arthritis. As you can see, the space on the inside side of that is almost completely obliterated. And this is a side view of that same knee, and there's a fairly significant amount of arthritis as well underneath the kneecap. And this, again, this is someone who has pretty much symmetrical arthritis on both sides, and it's on the inside of both of his knees. And what that does is that makes this patient develop a bowed deformity. This patient will have pretty significant bow legs because the medial side or the inside side is collapsed and the knee is no longer straight.
And he's very uncomfortable.
Very, yes. And does not walk well either.
No, sure not.
Now this is just a picture in the operating room. When I first started, they had medium and large were the two sizes of knees. Now there is this massive array of sizes, which means we do a much better job of fitting them to the patient. It also means there's a lot more equipment, and that's our nurse standing there just getting the equipment ready to start the case.
So your prosthesis, are those little round things that you see?
On this double-decker tray there, these are trial prostheses are on the top left. And that's just an operative picture. That's myself in the foreground, and a nurse helping me, and the nurse in the background is called the circulating nurse. And we're just in the process of putting in a joint. Now this is a picture after the joint's put in, and you can remember from the model we showed there's an artificial thigh bone and artificial shin bone that are just, you've taken just a little bit of bone off and then you fit those back in and cemented them into place. And you can see, you asked about the length of the incision. If you look just above the thigh bone prosthesis, you can see about 4 or 5 staples, those little, you can see how they're white on the x-ray, and there are a couple of staples below the tip, so you can see how long that incision is.
People may be interested in knowing what kind of cement.
The cement is called methyl methacrylate, and it comes as a powder. We mix it up, and it's usually very hard within about 10 minutes. So you have to have everything ready. You do a trial reduction to make sure everything fits well. Then you mix the cement and you put it in quickly so it doesn't harden before you get done. And this is a side view of the same patient. You can't see the artificial kneecap because it's not metal, so it doesn't show up on the x-ray, but that's the same knee just looking from the side.
All right, initially, joint replacement was a really lengthy procedure. I remember when we started doing it at Lynchburg General, takes a lot less time now. Approximately how long does it take to do a knee replacement?
It takes around an hour. Sometimes it'll take you 90 minutes, which would be unusual, and sometimes it'll take you 50. But because the guides and the machinery is so much better, we have become quicker. And the other thing is, there used to be lots of different kinds. Now there are less kinds, and because surgeons aren't putting in all bunches of different kinds, the nursing staff are used to it, and the whole team is much more efficient at putting it in.
How functional is this artificial prosthetic knee in comparison to the patient's own joint?
The artificial knees are actually very functional. I don't like a patient who has an artificial knee to be a distance runner. I would caution them against being a singles tennis player, but I would let them bicycle, I would let them walk, I would let them play doubles tennis, I'd let them ski. So basically, other than significant impact exercise, they can do anything they want. And these are tested with these machines for millions of cycles. They hold up beautifully. They really are very durable, and your life has not changed much by having a knee, except for the people who have it. They feel a lot better than they did before.
We know a roofer who has had both of his knees done. He's still up on the roof, down on both knees. I don't know how he can do that, but you know, it's just an individual thing, I guess.
It is, and some people push it more than others, and there's no problem with being on the roof as long as he doesn't fall, but there's nothing about that that would put that knee at risk.
With any surgical procedure, as long as I've worked in the operating room, I certainly know this, that complications may occur. Are there any specific complications that you would look for with something like this?
The complications in a knee are really the ones you would predict, and there are a few that you might not. But anytime you have surgery, you have a risk of infection. The infection rate's very low, but it does happen. Anytime you have surgery, you have an anesthesia risk. Again, it's very low. One of the complications that's more specific for a knee is a blood clot. Anytime you operate on a big bone in the leg, there's a higher risk of blood clotting. We give the patients medications to limit that risk. But again, it is a risk. It happens very rarely, but it can be a significant thing when it happens. Those are really the major risks that we see. Bleeding is quite unusual of any significant nature, you know, any life-threatening nature.
What happens to this good knee while your other knee is recovering?
A little bit of that depends on how good or bad that knee was. I do think for most patients it's better to have a quote-unquote good knee or one that hasn't been operated on to walk on. If the knee is angulated, if the non-operated knee is angulated, then it's tough, because what happens is you straightened the one knee and the other one's still crooked. And obviously the other knee is going to take more pressure initially because the patient's not going to be walking smoothly. But you're not going to do any harm to the other knee. It's just more a matter of how much it limits you and how much it likes carrying more of the weight for a period of time.
So if you've already got a problem with that knee, is it likely to push it over the line?
I don't know that necessarily push it over the line, but I think it's going to make it more sore. The one thing to remember about a knee replacement is the replaced knee can bear full weight right away. It's ready to bear weight right away, but because of pain, patients often don't put full weight, and so they do often shift some stress over to the other side.
How often do you do both knees, or do you ever do both knees at the same time?
I do both knees at the same time when a patient wants it. It is more surgery. It is more blood loss. It is more pain. And if a patient understands that and wants it done, I will do it. I think there are pros and cons to it, just kind of as an individual decision.
I can't imagine having both done at the same time, but I know some people who do.
Yes.
What's the life expectancy of this prosthetic knee?
The life expectancy when I first started was felt to be quite short, and people thought that the hips were going to last longer than the knees. The knees have actually done much better than initially expected, and lots of us have replaced knees that have been in patients for longer than 20 years. Oh. If you don't have an early problem with a knee replacement. I think nowadays you can expect it to last 20 years. I mean, they are, and like I said, a lot of them are lasting longer.
You know, when I had mine done, I asked the sales rep.